Good morning, everyone. Welcome to the Young Physicians Forum for the February. Today we have two speakers to presenting in this forum. So before starting, I have to just announce you that the Young Physician Forum, the lectures has to be finished with questions in 30 minutes. So by 25 minutes, we will warn you, and we will not allow you to go beyond 30 minutes. We have to stop because, so make sure that you finish by 25 minutes, have time for questions for us to proceed in according to time schedule. So to start today's proceedings, can I call upon Dr. Yanushka Herath, MBBS MD, Senior Registrar and Cardiologist, Sri Jawadharma General Hospital, to talk to us on rheumatic heart disease, forgotten but not gone by. Can Yanushka please take the podium?
Thank you, sir. Good afternoon, ladies and gentlemen. Today, first of all, let me thank the Ceylon College of Physicians for organizing this Young Physician Symposium, and I consider it as a great privilege to talk in this prestigious forum. So today my topic is about a long forgotten disease, rheumatic heart disease, and also I want to describe about the spectrum of the diseases. So my main objectives are to highlight an overview of the spectrum of this disease and to highlight the current global trends, and then to discuss on the updates of the pathogenesis and the management, and to talk about the mysterious penicillin related deaths, and then to talk about subclinical rheumatic heart disease, the hidden problem, and also to discuss a possibility of a rise in Sri Lanka. So these are my subtopics for this talk. And for starting on with the historical aspects, first is that the major clinical manifestations of rheumatic fever was first described back in 1685 by Thomas Sydenham, and then Dr. Sorry about that. So I'll start from where I stopped. And talking about the historical aspects, so it was that Dr. W.D. Sheedle was the first person to propose the modern concept of the rheumatic state in 1889. In the opening remarks of the historical lecture was that there is perhaps no serious disease more familiar to us than acute articular rheumatism. So in 1944, a criteria was established by Dr. T. Duckett Jones, and it was revised all throughout the years, and the final criteria was proposed by the American Heart Association in 2015. So this chart is an important chart. So this highlights the crude death rate from rheumatic heart disease in the United States of America. We can see here that even before penicillin was used as a secondary prophylaxis, we can see that the death rate of rheumatic heart disease was declining. This was mainly due to the improvement of socioeconomic standard and the housing conditions. And in the latter half of the 20th century, there was a dramatic epidemiological shift which unfolded, and the disease virtually disappeared in almost all the high-income countries. So from becoming a truly global disease in the 19th or the 20th century, it became on to be a disease of crowding and poverty in the 21st century. So talking about the global disease burden, firstly, rheumatic heart disease, as we all know, is caused by group A streptococcal infection. And due to the high risk of premature morbidity, mortality, and disability, rheumatic heart disease remains a critical public health issue worldwide, especially in low-income countries. And although eminently preventable, despite having such a knowledge for more than 100 years, rheumatic heart disease remains the most common cause for cardiovascular morbidity and early mortality in young people worldwide. And despite the high incidence in under-resourced settings, the disease is missing from major global health discussions as well. So as a part of the 2015 Global Disease Burden Study, the global, regional, and national burden of rheumatic heart disease was estimated. So we can see here that in our region, Sri Lanka, in the Global Disease Burden Study, actually they divided as endemic and non-endemic countries based on the deaths per 100,000 population by rheumatic heart disease. So we can see here in our region that Sri Lanka is the only non-endemic country which we all can be proud about. And currently, there are more than 40 million people living with rheumatic heart disease, and out of that, more than 300,000 patients die each year. And the estimated age standardized prevalence of rheumatic heart disease in 2015 was more than 400 cases per 100,000 population in endemic countries, and in non-endemic countries, it was 3.4 cases per 100,000 population. And also there are plenty of severe heart failure cases, which is estimated to be more than 600,000 in the year 2015. So the same study, they also estimated that every 10 persons per 1,000 populations living in South Asia is having rheumatic heart disease, which is a very high number considering the statistics. And a disease of the poor, rheumatic heart disease in the developing world, it has reduced the attention given by the scientific and the medical communities. It is reflected by a low number of publications, conference papers, and even poor media coverage regarding this disease. A recent analysis had shown that rheumatic heart disease receives the least funding relative to 16 other tropical diseases. So this graph highlights, we can see here that the global disease burden was estimated by the disability adjusted life years, and comparing with the funding for research and development, we can see that although the disease burden is extremely high in rheumatic heart disease, the funding is very minimal. We can see that in comparison to HIV and tuberculosis, although disease burden is high, their funding is also extremely high. And rheumatic heart disease is known to cause significant disability in the affected individuals, and especially when in case of multivalvular diseases. So in diseases like HIV, the loss of productivity is acute, but in rheumatic heart disease, the loss of productivity will be scattered throughout years and even decades. And the economic burden is the least addressed aspect, because no one knows what is the economical burden, especially in developing countries. And it is estimated that sum of $2.2 trillion is lost worldwide annually for rheumatic heart disease alone. And talking about the disease biology, so okay, we all know that acute rheumatic fever, it is a post-infectious syndrome involving heart, joints, and subcutaneous tissues. And 60% of those with carditis, they develop residual valve damage, which is known as rheumatic heart disease. So the greatest risk of developing acute rheumatic fever is in the age group of 5 to 15. And of course, rheumatic heart disease occurs several decades later when they are about 25 to 45 years of age. So now all patients who are infected with rheumatic fever, only about 3 to 6%. So that means that there are other factors responsible, such as socioeconomical factors, virulent strains, and host susceptibility, and also genetic factors as well. So this slide highlights the impact of low socioeconomical status, especially on unhygienic living. It causes a persistent group-based streptococcal infection, and overcrowding. It can cause repeated group-based streptococcal infections, and of course malnutrition, which reduce the immune response, which will result to be an endemic rheumatic fever. And after the first episode, usually there can be a diagnosed, undiagnosed mild rheumatic heart disease, which will be asymptomatic, and no prophylaxis will be given. And there can be repeated attacks, and then the patients can go into a symptomatic or more severe form of rheumatic heart disease. And the best way to describe about this disease is to talk about a population which rheumatic heart disease is endemic. So the Australian Aboriginal communities, they are known to be the highest prevalent communities with rheumatic heart disease. They are scattered throughout Australia, although initially they were known to be in the northern part. And studies show that acute rheumatic fever rates are more than 300 cases per 100,000 population among this community. And also high proportion of cases presented with cardiac abnormalities. And surprisingly, these populations, their throat carriage of group-based streptococcus was pretty low. But they showed that impetigo caused by group-based streptococcal was high in these communities. And also, interestingly, these studies show that there was a high incidence of group G and group C streptococcal pharyngitis in those with rheumatic heart disease. So that is implicating that these strains are also responsible for the etiology of acute rheumatic fever. So there are two mechanisms which we can describe. First thing is the molecular mimicry, which we all know about it. And the new notion is the new antigen theory. So the new antigen theory is about the group-based streptococcus organism coming to the pharynx epithelium, and it gets embedded in the basal cell, in the basement membrane, which there's abundant type 4 collagen. So what happens is there is a C83 group in this type 4 collagen, and the M protein binds and it becomes extremely immunogenic. So as a result, there will be anti-collagen antibody formed, and it will cause a systemic inflammation by that. So this will result in valve damage and valve destruction further on. So I think this cartoon clearly highlights what molecular mimicry is about, so I will not explain about it. And talking about the clinical features, first I want to talk about the acute rheumatic fever. So this is how the original Jones criteria, which is divided as low risk population and moderate to high risk population. Low risk population was defined as acute rheumatic fever incident was less than 2 per 100,000. And we can see here that they have incorporated the subclinical entity, which is the most important thing in this criteria based on the echocardiographic findings. And in the moderate to high risk population, they also incorporated monoarthritis and polyarthralgia as a major criteria, which was very much different from the previous criteria. And then in some circumstances, I think we all have seen it as well, that in some circumstances that the criteria with the Jones criteria, we cannot diagnose acute rheumatic fever based on laboratory unavailability of the test. There is lack of documentation of the clinical features and the unreliable history. So in these circumstances, it is wise to label them as possible rheumatic fever, and we can actually treat. And then the clinician has the role here to decide on offering secondary prophylaxis. What the guideline says is to continue antibiotic prophylaxis for 12 months, followed by re-evaluation. And then carditis in the diagnosis of the era where echocardiography is widely available. So in traditional days, in the early days, initial carditis, it was diagnosed based on auscultation of a typical AR, aortic regurgitation or a mitral regurgitation. And although carditis of acute rheumatic fever has been considered to be a pancarditis, valvulitis is the most consistent feature. In fact, myocarditis or pericarditis isolatedly happening in acute rheumatic fever is extremely rare, and it is even not cardiography. It is being used increasingly to diagnose carditis. So the concept of subclinical carditis has emerged, and it is incorporated in the guideline and consensus as well. So subclinical carditis is classical auscultatory findings of valvular dysfunction. They are not present or not recognized by the diagnosing clinician, but there is presence of echocardiographic evidence of mitral and aortic valvulitis. And so the guideline has recommended echocardiography in all cases of suspected acute rheumatic fever, and also in cases where we are suspecting acute rheumatic fever and carditis is not present, they recommend to perform serial echocardiography until the detection of carditis. So these are the features of acute mitral valvulitis, echocardiographic features. And well, there is a transition from rheumatic carditis to rheumatic heart disease, followed by repeated episodes of acute rheumatic fever. And although chronic rheumatic heart disease occurs only as a sequel to acute rheumatic fever, it is very important to note that majority of patients with rheumatic heart disease, they lack a history of past history of acute rheumatic fever. So that means there is these patients go asymptomatic for a time. So this suggests that acute rheumatic fever is frequently being missed, or it is subclinical, or it is not detected. And talking about clinical manifestations of rheumatic heart disease, well, it can present as heart failure, pulmonary hypertension, atrial fibrillation, stroke, infective endocarditis. Rarely it can present at the first time during pregnancy, and also following incidental auscultation of a murmur. And rheumatic heart disease, typically it affects left-sided valves with greater affinity towards the mitral valve. And isolated aortic valve disease can occur about 2%, and also right-sided valve disease, that means the tricuspid valvulitis, is not uncommon as well. But isolated pulmonary valve involvement has not been documented. And acute rheumatic valvulitis, they initially manifest as valve regurgitation. But over time, what happens is there will be chronic inflammation, which lead into valve stenosis. So as a result, there will be commissural fusion with or without regurgitation. And mitral stenosis from commissural fusion is the hallmark lesion of late stage of rheumatic heart disease. And of course, the fulminant course of this disease spectrum is directly linked to recurrent bouts of acute rheumatic fever. And screening. Now, why screening is important? Because rheumatic heart disease, it carries a high risk of morbidity and mortality, and the 2-year case fatal rate is nearly 16%. So timely diagnosis and treatment of group-based streptococcal infection will not prevent all cases, because there is a subclinical population. And then access to life-saving surgical catheter-based interventions are also limited, especially in a setting like Sri Lanka. And the auscultation of a pathological murmur was the traditional approach, but it is not sensitive or specific. And their recent studies show that when you compare echocardiographic with the auscultation, the detection was increased to 5 to 50-fold extent. So echocardiographic is important in that circumstances. And echocardiography case finding appears to hold the most tangible hope in detecting these cases, especially in a stage where secondary prophylaxis will have a greater chance to succeed. So question is whether screening with echocardiography is practical, especially in a situation in a country like us, in a resource poor setting. And next, ladies and gentlemen, I want to highlight the management, and I will highlight it based on these topics. The management can be initially the primordial prevention, which is reducing the group A streptococcal exposure. It is done by improving reducing social contacts, improving the household condition, washing and the bedding, and all these factors contribute. And then the primary prevention, once the patient develop a group A streptococcal infection, treating the patient with antibiotics. So several factors are important there. Availability, transportation, and availability of antibiotics, all these factors are important. And then the secondary prevention, when the patient develops acute rheumatic fever, stop the patient from going into a rheumatic heart disease. And treatment of acute rheumatic fever, so basically, first is you need to eliminate the group A streptococcal infection, so you can give antibiotics. So in penicillin is the preferred choice, oral penicillin that is the preferred choice, and then is to suppress the inflammation. Traditionally, aspirin is the drug of choice to suppress inflammation, but recent studies show inflammation and its efficiency was also higher than aspirin. And in severe heart failure patients, actually there's a place for steroids, and in life-threatening heart failure, life-threatening conditions, IV methylprednisolone can also be used. And then talking about antibiotic prophylaxis in rheumatic heart disease, well, following the initial episode, patients are at high risk of developing another episode of acute rheumatic fever. And rheumatic fever becomes less common after 25 years, and it is even rarely seen after 30 years. So treatment of symptomatic streptococcal infection is not adequate to prevent all cases of acute rheumatic fever going into severe heart disease. So therefore, the arise needs of antibiotic chemoprophylaxis. Now, traditionally, we use IM benzathine penicillin, which is the first line, and it is the drug of choice. And plenty of studies, they show that benzathine penicillin is more superior to oral penicillin low. And recently in Sri Lanka, that lack of penicillin has emerged, and as an alternative, erythromycin can be used. So these are the durations of penicillin prophylaxis. Now, several guidelines, they highlight different durations, but this is from the American Heart Association. And when there is rheumatic fever with carditis with residual heart disease, antibiotic duration can be 10 years or until 40 years, whichever is longer. And when there is no residual heart disease but carditis, then up to 10 years or 21 years, whichever is longer again. And in circumstances where rheumatic fever without carditis occurs, you can give it up to 5 years or until 21 years, whichever is longer. So after giving antibiotics or after the duration is completed, we have to again assess the patient, the severity of the valve disease, and the potential risk of group A streptococcal exposure. So in these circumstances, the clinician can decide whether lifelong antibiotic prophylaxis is needed or not. And it is also important to note that prophylaxis should be continued even after valve surgery, including prosthetic valve replacement. So these are the problems of benzathine, obvious problems of benzathine penicillin prophylaxis: pain, difficulty in attending clinics, financial constraints, and fear of adverse effects and poor knowledge. So as a solution, we can improve the nurse-patient relationship. There had to be a dedicated staff to give benzathine penicillin injection, and patient education also plays a risk and plays a role. And until recently, deaths in minutes to hours after the benzathine penicillin injection was thought to be anaphylactic related events. But however, there's a growing number of reports that says that these deaths are not due to anaphylaxis. They did not show features of anaphylaxis. And even if you consider the true risk of anaphylaxis following benzathine penicillin, they're extremely low. So this point out towards a cardiovascular compromise as a possible cause for these mysterious benzyl penicillin related deaths. So these deaths, they are predominantly hemodynamic. So they have postulated a theory. Maybe it is a benzyl painful injection causing hypotension due to a vasovagal attack, causing reduced coronary perfusion, and then resulting in ventricular arrhythmias and death in a pre-existing cardiovascular compromised patients. This is a possible mechanism, and these further become complicated when the patients are dehydrated, they travel long distance for injections, they are hungry, and they have to stay in long queues. So all these factors contribute in these deaths. And this is a study done in 2019 of 10 cases of these mysterious deaths, and all patients, they had echocardiographic evidence of valvular disease, and all received benzyl penicillin prior to the event, and 8 cases, they were fatal. And in a recent Khartoum study, the Khartoum registry composed of more than 800 children with rheumatic heart disease, and they experienced 3 children with sudden collapse following the benzyl penicillin injection. And all of these children, they received appropriate treatment for anaphylaxis, and they did not have any features to suggest anaphylaxis, and all 3 had severe mitral regurgitation. So question is whether these deaths are related to rheumatic heart disease. So of course, there was a clear association between the adverse outcome and the severity of rheumatic heart disease. And if anaphylaxis occurred, it should be an equal distribution. And in those receiving benzyl penicillin injections for other reasons, they did not get such deaths. So, and also these patients, they did not have an appropriate response for anaphylaxis treatment. So all these things, they point out towards that this is related to rheumatic heart disease. So these cases, they have led to a growing global dialogue questioning the benefits of benzyl penicillin injections. And this can cause anxiety among patients, families, healthcare professionals, which can reduce the delivery of benzyl penicillin injections. And as the evidence base for these reactions are very low, and there's no formal risk had been done regarding the risk mitigation, there's no sufficient evidence to put into a guideline as well. So, penicillin reactions in these patients with severe rheumatic heart disease, a presidential advisory from the American Heart Association was published last year, August. And this states to divide the patients as 2 categories, the high risk and the low risk category. High risk category was patients with severe valve diseases and an ejection fraction of less than 50 and NYHA class 3 or 4 dyspnea. So what the AHA recommended was to give oral penicillin in these high-risk patients instead of giving a IM benzathine penicillin. And so the best practice to reduce the risk of collapse is to minimize the pain, keep the patient hydrated, make sure the patient have had a snack before the injection, and administer the injection in a supine position, and also ask the patient to remain in a supine position about 5 minutes after the injection. And the next question is whether secondary prophylaxis is needed for latent or the subclinical population. So this was a recent study done in Uganda. They screened more than 100,000 patients. They found out 926 patients with subclinical rheumatic heart disease. So half of the population, they gave prophylaxis, and the rest, they did not give prophylaxis. So what they found out was the group who received prophylaxis, their progression to severe rheumatic heart disease was 0.8%, comparing with the control group of 8% progression. So it was statistically significant. But the question is whether patients will take prophylaxis when they're subclinical, because they are obviously they don't have symptoms. And so there's a question whether they will take the prophylaxis. So next, I want to highlight the general management of rheumatic heart disease. So of course, diuretic is the mainstay when patients are symptomatic. And in circumstances where isolated mitral stenosis is there, we can give them a beta blocker, which will improve the diastolic filling by reducing the transvalvular gradient. And when the patients have mitral regurgitation or aortic regurgitation, and ACE inhibitor can be given, which will reduce the afterload, and of course, warfarin in atrial fibrillation. So this is a new theory because ACE inhibitors are known to reduce the activation of cardiac fibrosis. And there's a theory, a hypothesis that ACE inhibitors will reduce valve fibrosis and thickening in rheumatic heart disease. But further studies are needed. This is only a hypothesis. And then the famous Invictus study. Well, I think we all know about the Invictus study. They studied 4,500 patients with rheumatic heart disease and atrial fibrillation. So half they gave rivaroxaban, half vitamin K antagonist. And the vitamin K antagonist led to a lower rate of cardiorespiratory events or death than rivaroxaban without a high risk of bleeding. So therefore, even in these atrial fibrillation patients who are having valvular disease, warfarin is the drug of choice. So then, of course, the catheter-based therapy and the percutaneous mitral balloon commissurotomy can be done, especially when mitral stenosis is pliable, non-calcified, and predominantly fused at the commissures is indicated. And of course, when catheter-based therapy cannot be used, then we can go with the surgical management of valve replacement or valve repair. And next, I want to highlight the Sri Lankan situation about the disease. So this is a crowded slide, and this I took it from the WHO website. We can see here that Sri Lanka has a very low death rate per 100,000 population, and I think you all can appreciate it. In the lower, the dark green line shows Sri Lankan statistics, and unfortunately, statistics are only available up to 2014. And this is the death rate of the 100,000 population, which you can see how it reduced from 2000 to 2014. And again, this highlights now in 1990, rheumatic heart disease was the 20th place for causes of premature death. And it has improved by the year 2010. We can see that rheumatic heart disease is the 34th place. So the number of deaths from rheumatic heart disease has significantly declined. But question comes, and this is the main reason for me to select this topic is as well. So currently we are facing an economic crisis, and the lack of resources, and our inflation is rising, foreign exchange is low, and we are going from crisis to crisis. And the World Bank estimates that Sri Lanka's ongoing financial crisis may increase poverty from 13% to 25% in 2023. So the poverty is going to double this year, and which is equivalent to over 2.5 million people falling into poverty during this period. And meantime, the inflation has gone up to 52% from January to July 2022. So how these economical crises can have an impact on the disease is now obviously poverty is increasing. So then there will be poor hygiene, and the primordial prevention will be less. So the spread of group A streptococcus will be high in the community. What happens when the group A streptococcus spreading is high? Patients will develop group A streptococcal pharyngitis. So they don't have money to go to a doctor, and if you go to a hospital, some circumstances medicine is not available. So group A pharyngitis will persist, and it will move on to carditis. So when they develop carditis, again due to lack of resources, they will not come to a hospital, and even if they come to a hospital, there will be no penicillin prophylaxis. So as a result, they will progress into advanced rheumatic heart disease, and then they will need valve surgery. And when valve surgery is needed, there is lack of prosthetic valves in Sri Lanka. So then valve surgery is also not readily available. And even if everything is available, there's a massive brain drain going on. And from a doctor's point of view, the primary care physician, the consultant physicians, the cardiologists, and the cardiothoracic surgeons are needed to manage the spectrum of disease. So what happens when everything happens and the brain drain is high, there's no one to manage these patients. So there's a huge problem. And my question is, do we need to worry about this? So I will stop my talk with this question. I leave this question to the audience to think about, do we have to really worry about this illness in the future? And these are my references. I would especially thank the Ceylon College of Physicians, and also I want to thank Dr. Jagat Therath, my supervisor and consultant cardiologist at Sri Jayawardhanapura Hospital, and also Dr. Navamali Amarasena, consultant cardiologist at Sri Jayawardhanapura Hospital. And I also want to thank the professorial medical unit of the Colombo South Teaching Hospital, where I did my internship and my registrar period. Thank you.
Please wait for questions. Of course, when the questions are asked from the audience, I have to repeat them for the virtual. Just give me a minute before you start answering. Any questions from the physical audience first?
One question. Now, in the patients, the common situation of dealing with support and situation. So, what's the on negotiations
So actually, it's a data consideration. Only the Invictus study was available, sir. And from the Invictus studies, sir, the death rates and the risk of stroke was very high when giving rivaroxaban. And so, sir, it clearly concluded that warfarin is the choice. But, sir, these studies were not performed, especially in South Asian settings. And other things, sir, generally studies are very low in rheumatic heart disease per se. So actually, sir, for now, evidence shows that warfarin will be the choice in considering rheumatic heart disease and atrial fibrillation. Sir.
studies in the Asian region where they have used
And no, sir. Apart from that, sir, there were no studies.
Yeah, that's for the virtual audience. The question was on difficulties in monitoring warfarin therapy in some of the patients, and what's the situation regarding the liver, the anticoagulants. So that's what the Yanushka answers on. Any other questions from the physical audience? Anybody from virtual audience want to ask a question? I can repeat it from here for the physical audience.
Anushka, hello. Can you hear me?
Yes, I can hear.
Okay.
Yes, sir, go ahead.
What is the current situation in Sri Lanka? Is the benzocaine penicillin is used or oral penicillin?
Yes, sir. Actually, sir, we got I got a couple of calls, sir, one from Karapiti and one from our hospital as well, sir, from the medical units that benzyl penicillin is not available, sir. And they wanted, and even so, oral penicillin is not available, so they wanted to know alternative to use, sir. And so, actually, we suggested using erythromycin 500 milligrams or 250 milligrams BD or 500 milligrams BD, sir. And also, azithromycin is also a possibility. And actually, sir, in India, certain there's a trial in India which they have proven that giving azithromycin for 1 week daily dose, then followed by a weekly 500 milligram dose, and it has found to be successful, but it is still not incorporated in the guidelines. So for now, sir, what we do is we give 250 milligram daily dose of azithromycin or 500 milligram BD of erythromycin, sir. Actually, sir, the situation, lack of penicillin situation is there in the country, sir.
Thank you.
Yeah, the question from Dr. Raghunathan is on the situation of what prophylaxis we can use in event of not availability of the penicillins.